Hola, buenos dias. I am Dr. Lavinia Lumu, and I am the current president of the International Marseille Society. And thank you so much for inviting me today to the Red Latina de Salud Mental Perinatal Conference. So I'm going to share my slides of my presentation. And as I open my screen, I'd like to say thank you so much for the invitation to this meeting. And I am so privileged to be a part of this meeting. And as I get into it, um, I would like to go into a little bit of the current trends that are happening worldwide in perinatal mental health. So, as we know, um, we are the Marseille Society, and I'm sure some people wonder why we are referred to as the Marseille Society. And it all started in 1858 when a Dr. Louis Victor Marseille compiled quite an extensive report on what he observed at that time in 1858 of psychiatric changes that would happen in women following pregnancy. So that the work that he published at that time didn't receive much recognition until 150 years later. And he was actually one of the first people to identify that there are significant changes linked to um, mental health, specifically during the postpartum. So Marseille, referred to as the International Marseille Society for Perinatal Mental Health, started all the way back in July 1980, when at a conference, people came together and identified that more focus is needed in this field. If we look at what the World Health Organization has to say, it's quite concerning in that at least 10 pregnant women around the world suffer from some form of mental disorder. And this progresses to 13 people after giving birth. And what we are seeing is that it is quite high, up to 20 to 30% of mothers in low and middle income countries or developing countries have some form of depression after birth. So, if we look at the prevalence of antenatal depression, it's up to 20%, which is 1 in 5 pregnant women. And what we are noticing is that it's neglected and we're not paying attention to it. And because of that, if we look at the outcomes for the mothers, they don't follow up for their antenatal care. There's an increased risk of substance use and suicide. And during delivery, these moms are at higher risk of miscarriage, antepartum hemorrhage, cesarean section, and prolonged labor. And we also noticed that babies struggle as well. There's a higher risk of preterm birth, low birth weight, intrauterine growth restriction, small for gestational age babies, and an increased risk for neonatal ICU admissions. And let's not forget what happens in the postpartum when the mother gets home. We find that there's an increased risk of child neglect. These moms struggle to breastfeed. And of course, infanticide becomes an issue. Infanticide is very prevalent in my country of South Africa, where mothers often dump their babies or, unfortunately, kill their babies. Unfortunately, it's not well documented, though, in our setting. So if we look at what goes on in terms of the current management that is available to us, we have psychotherapy for perinatal mental health management. That's the first thing that we try to do, but we don't have enough perinatal mental health or mental health specialists in forms of therapists and psychologists. Also, antidepressants, there's a lot of headway in terms of the use and safety of antidepressants in pregnancy and mood stabilizers as well. And we also can use electroconvulsive therapy during pregnancy. And there's some newer treatments that we can use for the management of perinatal health conditions. So I want us to go throughout the world and just see what the current trends are. And what's fascinating is some of the practices and management that are undertaken in some parts of the world could be adapted to your setting. Starting off, a country which is a neighboring country to South Africa called Zimbabwe. And if we look at Zimbabwe, it's classified as a low and middle income country where there's only 10 psychiatrists for a population of 13 million people. So, really, a lack of mental health services. But what is fascinating, despite that, in 2006, Dr. Chibanda and his team went into the community and trained over 600 grandmothers in evidence-based talk therapy and created what is known as the Friendship Bench, which is quite an amazing initiative where it's run by lay health workers in the form of these grandmothers who provide 6 sessions of individual problem-solving therapy to the mothers. And what's nice is this friendship bench is right outside the clinic. So after the mother has done with her check of the baby, she can just go and receive some therapy. So quite an amazing initiative within the form of the friendship bench. If we go to the Gambia is a very small country in the west of Africa and has a population of 2 million people. So even though it's a very small country, it's the most densely populated country in West Africa. And, in that part of the world, there's a lack of accessing healthcare. Some people prefer biomedicine, indigenous or traditional medicine, and spiritual treatments. But despite that, there's been an amazing initiative in the form of research. And this research is done by a person who studied music and came up with an initiative for music-based psychotherapy in pregnancy. Ms. San Filippo is also a Marseille member, and part of the research as well is Vivette Glover as well, who's also a Marseille member. So it's very amazing that we have Marseille members as part of this research. So this research focused on women in the community of the Gambia, where they use music as a form of therapy. So it'd be 1 hour per week for 6 weeks. So all the pregnant women in the community would team up and join the group of singing women, and they notice improvements in these women's these pregnant mothers' mental health. So I'm going to play a video that demonstrates what they do, so that you can get an idea.
In a UK context, about 1 in 5 will experience anxiety or depression during pregnancy. And in low-income contexts, this can be twice as high because of the exacerbating effects of poverty. We're used to thinking about the mental health of women after they give birth and things like postnatal depression. But what we now know is that one of the biggest predictors of postnatal depression is antenatal depression. We also know that a woman's mental state during pregnancy can elevate the risk to the developing fetus in terms of psychological and behavioral problems later on in life.
One of the things that music can do during the perinatal period is create a bond between the mother and the developing fetus, as well as once the infant is born. So if you think about lullabies, they exist in every culture. You have play songs, you have nursery rhymes. We also know that music is a very good communicator. It's very easy to communicate a message through music. So our intervention is sort of intertwining the two.
So the project I'm working on at the moment is actually based in West Africa, in the Gambia. And we're looking to see how existing musical traditions and musical practices there can support women's mental health during pregnancy.
One of the reasons we wanted to be there was because of the Kenneling women, which are these fertility societies. So they're all female groups that have dealt with infertility or have lost a child within the first year of life. And one way that they cope with that is to support one another through singing and dancing. They perform lots of rituals to support reproductive health, as well as perform in a lot of community ceremonies.
So I hope that video inspires you that despite a lack of resources, each community comes up with creative ways in assisting and aiding in perinatal mental health. So I just wanted to say a few words about mother-baby units. If we look at the UK National Institute for Child and Health Clinical Excellence clinical guidelines, they have recommended that women may need inpatient care for perinatal mental disorder and should be admitted to a specialized, what we call a mother-baby unit. The unit must have at least 4 beds, separate from other wards, and the facility must be a joint admission along with the baby to support the bonding and attachment process. It must be staffed 24 hours a day, 7 days a week. There must be a dedicated multidisciplinary team, and they must encourage breastfeeding, and there must be support and interventions for parenting and provide psychotherapy and also enhance the mother-baby attachment and bonding process, and also support to caregivers. In some parts of the world, mother-baby units are available, mostly in the UK and in Australia, and they're very expensive to run. A lot of people are required to run a mother-baby unit, and it's quite labor-intensive. But there is a country where they have successfully launched, and they have mother-baby units, and this is in India. India had its first mother-baby unit at Bangalore, at the National Institute for Mental Health and Neurosciences. And this is just an honor to talk about, Professor Chandra, who is a former Maasai Society president, and also now recently stepped down or finished her term as a president of the International Association for Women's Mental Health. So in 2016, she conducted research and demonstrated that they can start mother-baby units, even though they are classified as a low resource setting. They had 237 mother-infant pairs between 2009 and 2013. A lot of the women had bipolar disorder and acute psychosis, and they ran the unit with success. So it is possible, even with limited resources. So a few words on the exciting developments in treatments for postpartum depression. So if we look at the neurobiology of postpartum depression, we've had a breakthrough in research. They have found that there's a neuroactive metabolite called allopregnanolone, which is an active metabolite of progesterone, and it binds to the GABA A receptors. And when it binds to the GABA A receptors, it not only has anxiolytic effects, it also has antidepressant effects, and it's found to be low in specific conditions, such as not only postpartum depression, but also for PMS, which is premenstrual syndrome, and premenstrual dysphoric disorder. So that is exciting. So if here's a graph just demonstrating what happens when we are pregnant, the hormones increase, and then there's that sudden dip in hormone, which then predisposes the mother to depression in the postpartum. So what is exciting is because of that, there are new medications that have been developed, which are mostly available in the United States of America, starting off with brexanolone, which is an intravenous version based on allopregnanolone. They have come up with a similar molecule, which aids in a rapid improvement in the postpartum depression symptoms. Within a few days, the patient will feel better and is able to go home. It was launched in 2019, but the problem is that it does cost quite a lot of money, up to 34,000 US dollars, and a patient has to be in hospital for the 5 days when they are receiving the intravenous drip. Then there's another medication which was launched in 2023, similar to brexanolone, but this is now an oral tablet, zuranolone, which can help to improve postpartum symptoms within just 14 days. So that's really exciting. And also, there's a lot of new research in the space of transcranial magnetic stimulation in pregnancy. And this is based off a non-invasive treatment. So it's a lot safer, it's non-invasive, less intense, whereby they use magnetism and electricity and to promote activity in specific areas of the brain, leading to an improvement in symptoms. So for postpartum depression, it can be utilized. It is registered for use by the Food and Drug Administration in America for treatment-resistant depression. So it's quite exciting, the work that they're doing there. So we are so excited. So in summary, there's a lot of research happening in perinatal mental health. We are at a point that, you know, we can treat these common perinatal conditions, and we need to try and come up with interventions that are cross-cultural and overcome economic barriers so that we have improved outcomes for mother and baby. And with that being said, I would really love for you to join the Marseille family. Take a look at our website and join today and be part of the family. And I really hope that you would be able to join us next year in 2026, where the Marseille Congress will be taking place in Cape Town, South Africa. Thank you so much for your time, and I hope that we meet face to face soon. Bye.